We talk about rehabilitation and restorative nursing care, and that is the type of care that we're going to do to help somebody get back to their most optimal level of functioning that we can. So when we're taking care of a person, there are some key terms that we'll look at. We look at activities of daily living, and we said that is generally what a CNA does. The primary purpose of a CNA is to help the person with activities of daily living. So when a person has a disability, which is any lost, absent, or impaired physical or mental function, it can be from an acute problem that happened, or it can be a chronic issue. Maybe they have chronic back pain, or they have chronic hip issues, or knee issues, or it can be something acute that's a major surgery that they're trying to rehabilitate from. But we're going to help them with the activities of daily living that they can't do for themselves. One thing we always have to keep in mind when we're talking about rehabilitation is our goal is not to do everything for another person. Our goal is to help them get to the best level, the highest level of functioning that we possibly can, so they can do things for themselves. So that's always what our goal is going to be. Now, some people might have a prosthetic device, and a prosthesis is an artificial replacement for a missing body part. Now, let's see why this is. So when we talk about restorative nursing care, our goals are again to obtain the highest level of functioning as possible. We want to prevent decline. Now, when I say we're going to promote the highest level of functioning, some disease processes, so for instance, if you have a resident that has multiple sclerosis and their disease process is continuing to get worse, it doesn't matter how much exercise, how much range of motion, how active I try to keep them, their disease process is still going to make them get worse eventually. But we will do as much as we can to prevent decline or unnecessary decline, because we can slow the process down. And for instance, if someone has a stroke and they have weakness on one side, we can prevent further decline by exercising that side, by doing range of motion, by keeping them moving. So we will promote activities of daily living to the best of their ability. And we want to focus on the things they can do. We want to try to encourage them to be positive and to look at all as they're working on things and as they're struggling trying to get back their mobility or trying to get back to their best ability that they can, we want them to try to focus on all the positive things that are happening for them, not the things that they can't do. Restorative aids are generally nursing assistants that really enjoy that part of care where they're really working with patients on range of motion and movement and walking them. And usually the restorative aids, they're nursing assistants that work at a facility, and then they may actually work with physical therapy aides, with the physical therapist to learn how to move patients better. And so usually it's more of an on-the-job type of training. There are some schools that offer restorative aid training, but usually around here I've generally seen it done more of an on-the-job with physical therapy type of training. Rehabilitation for a person is a team effort, because we need to not just, when we're talking about rehabilitation, it's more than just the thing they came in with. So let's say they came in because of a knee replacement. They're more than a knee replacement. We have to look at how that knee replacement is impacting their entire life, emotionally, physically. Is it just the knee they're having issues with, or because of their movement are they now having incontinence issues? I mean, we have to look at the whole person, and that's what we're always going to be working on. Rehabilitation starts with admission. So when we admit a person into a facility, we're looking at that point right there. What do we need to do to get that person better? What do we need to do to get them to the best level of functioning that we can? Now, these are some of the devices that you might see in a facility. So there are like a wrist. This is kind of a wrist protector. It'll kind of keep the wrist straight. So if someone has a stroke and their wrist is starting to drop down, this will keep it in a more natural position. You might notice like a splinting type of device for somebody to keep their foot and their leg in a proper position. Walkers are used a lot in the nursing home as a walking aid, so they can have more mobility without having to have as much help. And then people will have a lot of times adaptive devices as well to help them be able to feed themselves. So we have large handled silverware, We have silverware that actually is attached to the wrist so it won't fall off, or so if they do have a hard time gripping, they can hang on to it a little bit better. There are plate guards, and plate guards actually keep the food from sliding off their plate when they're trying to, spear it with their fork or pick it up with their spoon. That way it doesn't just fall off of the plate as they're pushing it around. Canes, there are 4-point canes and 1-point canes. The 4-point canes are a little bit steadier. Generally with canes are used on the person's strong side. We always walk a person on their weak side. There are devices to help people button their shirts, to help pull on their shoes. There are seats for the showers. Now in the nursing home we actually have shower chairs, but if the person is going home, they can actually get a shower chair that will fit in their tub. And as I mentioned, there's different types of silverware as well that can be adaptive. But when we are rehabilitating someone, I said we look at the whole person. So we look at the physical aspects of it. Do they need help with elimination now? If they're having a disability, do we need to worry about, that they're going to have issues or problems with elimination? We're going to look at self-care. Do they need help with activities of daily living? Do they need to be retrained on how to give their own self-care at this point? Do they need help with mobility? Do we need to teach them how to walk again, how to use a cane, how to use a walker? Nutrition, okay, because of the physical aspects of whatever their disease process is. Do they have special nutritional needs? Do they need to be taught how to eat again? Maybe they have difficulty swallowing because they've had a stroke, and so they have to be on a special diet, or we have to kind of teach them to eat slower, or so they don't end up having issues with aspiration. Communication. Patients with strokes a lot of times, or head injuries, they have aphasia, where they have difficulty speaking, difficulty getting their words out. Possibly they might need help with breathing. They might need a mechanical ventilator, or they might end up with a tracheostomy. So there's a lot of potential aspects when a person has a disability that we're going to be looking at and helping them with whatever is needed. There's also obviously psychological and social aspects. We need to remember to give encouragement as much as we can to try to get them to see, any small successes that they're making in their improvement. We really want them to focus on those. We need to be good listeners. These patients are going through a lot. They have a lot of concerns. They're upset. They're frustrated. And so sometimes they just need a person to listen to be able to vent to. We want to provide choices as much as we possibly can. And we also need to remember to show empathy, to kind of picture ourselves in their place of how difficult what they're going through must be. Another aspect is the financial difficulty. If you have a major disability, not only are you having these physical things that you're having to fix and take care of, now you're also looking at financial issues as well. Maybe you can't work anymore, and your family relied on your job to be able to support them. The financial components of healthcare itself can be astronomical for people as well. So we have to look at that component as well. And we'll usually get social services involved to help them with insurances and resources and to see what other avenues that we can explore for them. Some complications that we see from disabilities, depression is one of them. So we do tend to see a lot of people feel very depressed when they are disabled, when they can't move the same as they did before, or if their quality of life has been impacted in some way. So we may need to get them psychological help with that. Some people that we'll see with disabilities, they will end up with pressure ulcerations. So this is a pressure ulceration on the heel. Heels are a really typical place to see them. The sacrum area on the bottom is a very, very probably the most common place we'll see pressure ulcers. There are other places. You can get them on shoulders, you can get them on the scapula, you can get them on the ischium if they're sitting up all day. There are other areas that will see pressure ulcers, but I would say the sacrum and the heels are pretty common. And that's just from laying in one position too long, not being repositioned enough. You can see things like foot drop, so if a person can't move their feet or support weight on their feet anymore, and if we're not doing good range of motion, we can actually see the foot start to drop where they won't be able to pick it up later. They might have issues with elimination issues because of their lack of their disability or their lack of being able to move in a certain way. And contractures. Contractures are an abnormal shortening of a muscle, and so you tend to, hands are a really common place we see it. They kind of curl in, and if we aren't doing range of motion when a person can't move their extremities and this starts to happen, we can't always get it back all the way, or sometimes the only way they can get it back is to surgically go in and release tendons and muscles and straighten it back out and then go through a lot of therapy. So we should be preventing these complications from happening. So one of the ways we do that is with range of motion. Now, range of motion, there's different types of range of motion. There's passive range of motion, where we are passively moving the person. There is active range of motion, where the person can do it themselves. You just maybe need to remind them or encourage them to do it. And then there's active assist, where they can move it to a certain point, and then we will continue to keep moving it for them. So when we're moving an extremity, we always move it gently and we always support it. So if you're moving the knee, you're wanting to do range of motion to the knee, we're going to, well, actually this one here is more of a hip motion right here. So here, bringing the knee up and down like this, you're actually working this hip joint more. To really get the knee joint, you're going to want to bring this and you're going to flex this all the way down to here so you get that full bend of the knee. But when we're moving people, we would support them at the joints. So I would be supporting them here at the knee and at the ankle. I want to make sure I move them gently. I move it through its full range. And always remember, if a person's starting to complain of pain when you're doing range of motion, you would stop and you would let the nurse know. We would provide privacy. Make sure you pull your privacy curtain, and if they're not fully clothed, of course, if we are doing this while they're in bed, if they're not fully clothed, we would only uncover the body part that we're actually working on. And the other thing I want to say about range of motion is a lot of times the physician will order how many times to move each joint. So frequently the physician will say range of motion 3 times a day, 10 times to each joint. Okay, so that means each joint I'm going to move 10 times. If it's not stated how many times you're supposed to move it, generally you'll see it done at least 5. If you get this skill for state competency, if you have to do range of motion to the shoulder or range of motion to the knee and the ankle for state competency, they will require you to do it 3 times each. But again, they're just looking for snippets of care. So usually you'll see an order for 5 or 10 times of movement to each joint, and usually 3 or sometimes even 4 times a day. So we do always want to remember quality of life. We want to protect privacy for our person, encourage choices whenever possible, encourage them to do as much for themselves as possible. Our goal is never to do everything for them. Our goal is to help them do as much for themselves as possible, and we will do the components that they can't do. We want to protect them from abuse and mistreatment. So if they have disabilities and they're not able to do things for themselves, sometimes it can be very frustrating for them. It can be frustrating for the people taking care of them. So we need to make sure they're protected from abuse and mistreatment. We need to learn how to deal with our anger and frustration. Sometimes when people are being rehabilitated, they're angry, they're frustrated, they lash out, and nursing is a safe person to lash out at. And sometimes we get frustrated. We just cleaned them up, we just did things, and then they need it again immediately. So it's something that if we're feeling anger or frustration, we need to make sure we take a break and step back, calm down, and if needed, even talk to the nurse about getting a different assignment. We want to encourage activities. We want to encourage these people to belong to the facility, to get involved at the facility. They need interaction with other people. So we want to encourage activities as much as possible and provide a nice, safe setting for them. Because the safety and security is always going to be a big deal. So we need to show patience, understanding, and sensitivity to our patients at all times when they're rehabilitating, because it is a frustrating process for them. And we will stop there.